Hey everyone, welcome to the November version of the Calgary R user group. Thank you very much for joining. We're here today to talk with Stephana, Dr. Stephana Julia Moss. If you take a peek on our bio on the Calgary R website, did most of her academic here in Alberta. Started off with the Bachelor of Science from University of Calgary, did her master's of pharmacology in Edmonton at the University of Alberta, and came back to Calgary to finish off and get her PhD in epidemiology. So today she has a technical talk talking about systematic review on meta-analysis. So with that, without further ado, I'd like to welcome Dr. Moss, and thank you very much for presenting today.
Great, and thanks so much for having me. And no worries, it's still I'm not used to the Dr. Moss even still, so totally fine. I actually prefer without it. It's way too formal. And thanks everyone for joining again. It's really great to see such a great a group that gets together, especially on a Wednesday evening, as people are trickling in after work to learn and to do something new that is maybe outside of R and is maybe a bit outside of boundaries of some of the things that you guys have potentially worked on in the past. And one of the best ways that I like to learn something new, or even to dig a little bit deeper in stuff that I might have a familiarity with, is to do a critical appraisal in the method of choice. And so that's exactly what we'll be doing tonight or today, depending where you're joining from. So the title of my talk is Meta-Analysis in Medical Research. And I'm going to start off with a bit of background, and then we're going to dive into a critical appraisal of a published paper in medical research. So what is a meta-analysis? Well, this was first coined by Carl Peterson in 1904, and his exact quote was that many of the groups are far too small to allow for any definite opinion being formed at all, and this is having regard to the size of probable error involved. Following that quote in 1904, one of the first uses of formal techniques for combining data from different studies was actually the meta-analysis. And this was done when examining preventive effective serum inoculations against enteric fever. Since then, the meta-analysis it's really exploded as this super powerful tool to accumulate and summarize the existing knowledge in a research field and to identify the overall measure of a treatment's effect. And that being said, while it's wildly popular and powerful, it's also quite controversial. And this is because there are several conditions that are critical, and even small violations can result in very misleading confusions. And this is exactly what we're going to dive into today. So my talk will be structured in four main sections. So the critical appraisal will be structured in four main sections. And we're going to actually pause after each of those sections. I have a question to raise to the group. So when I do pause and I have a screen that shows a question, please feel free to unmute yourself and engage a little bit, ask a question, state your opinion. That's really what those slides are meant for. So the first section that we will look at will be the identification and selection of studies. And that's because this is really the first reason to criticize the meta-analytic method. And this is because it provides evidence extracted and integrated from a number of primary studies, and it's not from a random sampling itself. The second place, or the second category, where we typically like to criticize or critically appraise meta-analyses is regard to publication bias and small study effect. Publication bias is the biggest potential source of type 1 error in meta-analyses, which is the increase of false positive results. And we'll also touch on something called the small study effect. And this occurs when small studies have systematically different effect from the larger ones that are included in a meta-analysis. Thirdly, we'll talk about the quality of included studies. And this is because the conclusions of a meta-analysis depend strongly on the quality of the studies included in the meta-analysis to estimate that final pooled effect. And then finally, which I'm sure all of you are most interested in, is the actual data analysis. And this is really the synthesis of the evidence that should reflect the a priori, usually published and registered analytic plan. And this states that the degree of heterogeneity among the included studies is another very important limitation. So we'll touch on that heterogeneity as well as the analytic plan itself. So before we dive into the meta-analysis, I just wanted to take a step back and look at the amount of information generated. You know, it really started off quite low, and relatively speaking, it increased massively throughout the previous years. And this estimate, this number, or this bar right here, was actually taken in July. So we can only imagine how much larger that bar is right now, especially after the COVID-19 pandemic, where a lot of research labs were moved to home. And we saw a lot of systematic reviews as well as scoping reviews published with meta-analyses. And that being said, it's crucial that we really critically appraise what's being published and how can we interpret and imply both clinically and in research purposes the information that is actually generated from this type of study design. So that being said, let's jump into the critical appraisal portion of this talk. The study that we will be looking at, I am biased. I did my PhD in critical care epidemiology. So we're going to be looking at an ICU or critical care medicine paper. And this one is Music Intervention for Sleep Quality in Critically Ill and Surgical Patients, a meta-analysis. And this was just recently published last March by Kakar and colleagues. So some key considerations for meta-analysis before you even get going are that the clinical question must be important to clinicians and the outcomes must be important to patients. So here are some three key considerations that we can take from the paper that we're critically appraising. First is that ICU and surgical patients have poor sleep, and this is known to be associated with a plethora of physical and psychological outcomes, so it's important. We also know that clinical practice guidelines strongly recommend against the use of pharmacological agents to improve sleep, such as benzodiazepines, given benzo's association with delirium. So therefore, sleep therapy might be an important non-pharmacological intervention. Music interventions in the ICU with patients have associated with decreased serum cortisol levels, state anxiety, respiratory rate, sedative and analgesic requirements, etc. So there has been enough research done on this topic in the critical care literature that a meta-analysis would seem practical. There would be enough studies to include. So that being said, when we take a look at the published paper, we can see that the aim of this paper is to assess and quantify current literature on the effect of perioperative recorded music interventions on sleep quality and sleep quantity in adult critical care and surgical populations. So as I mentioned in one of my previous slides, is that something that is really important to do is actually registering your protocol. So your a priori plan for the systematic review and meta-analysis. And that's because it can help to reduce the risk of biased post hoc decisions and methods, such as selective outcome reporting. Two registries that are typically, one guideline and one registry that is typically used to register and guide your systematic review and meta-analysis are PRISMA and Prospero. PRISMA is a set of accessible guidelines before work on the review begins. It helps to structure and set up your review. And you can also register your a priori plan on Prospero, which is an international prospective register of systematic reviews. And the reason why these are really important is because rigorous systematic reviews lead to more reliable evidence. And for this study in particular, we know that PRISMA was followed and Prospero was registered. This is a big check mark here. So now let's move on to that first section that we really want to dive into critically appraise, and that's the identification and selection of studies. So defining the population and the intervention is crucial. And this is because broad criteria increase heterogeneity between the studies, making it really hard to generalize findings, and narrow criteria make it hard to find studies in contrast. We also know that objective and reproducible serial search is required, and the search strategy should be comprehensive and sensitive. And we also know that searching more than one database is recommended. Study selection should also be independent and in duplicate, and this should be stated clearly how relevant studies identified in the database search advanced through the selection process. And I'll show the Prisma flow diagram in one of my later slides. So here on the left, I've showed the PICO or the PICO-S sort of groupings. And this is very common to structure the search strategy and the identification of relevant studies for your systematic review. The first is population. Then we move into intervention and comparator, outcome, and study design. For this study in particular, the population was critically ill patients admitted to ICU or CCU and or surgical patients aged 18 years or older. We know that the intervention was recorded music interventions, defined as the use of recorded music consisting of melody, harmony, and rhythm compared to a control group, or the most comparable group to the intervention if many groups were reported. The outcomes were sleep quality and quantity, as was reported in the AIM. And the study design that was included in the systematic review were randomized controlled trials. So the authors specifically searched and included RCTs. For the identification of studies, the authors used a standardized protocol that has been stated to have been validated at the Erasmus University Medical Center, Rotterdam, in Rotterdam, Netherlands. And I dig a little bit deeper. This actually wasn't in the published paper, but this standardized protocol that they use on the top here from left to right, we go from specific terms to more general terms. And then from top down, we go from important search terms to unimportant search terms. And this standardized approach is said to help with the identification of specific studies for their review. This is the search strategy that the authors published with their review, specifically for the database Embase. So from left to right, we go from specific to general. Apparently, I actually have a really hard time understanding this one. It's the first time I've seen this one used. And we go from top to bottom, important to unimportant. So here's an example of one of their search strategies that they used for Embase. However, the search strategy that they used only included terms related to intervention and comparator and outcome. They did not include any terms related to their population of interest and any terms related to their study design. So any terms related to randomized control trials. So while they nailed 2 out of 4, half ain't bad, I guess, they really missed terms for the other PICO elements, which is typically quite standard for any sort of comprehensive search strategy. So those were a bit of red flags or here, yellow exclamation marks that were raised to me. For their identification of studies, they use their search strategies in Embase, Medline, Cochrane Central, Web of Science, and Google Scholar databases, including articles published between January 1981, which was the year of the first minimally invasive surgical intervention. And this was to avoid any old literature that was not compatible with current standard of practice, and up to the 27th of January 2020. So I also took a little bit of a dive into their standardized protocol, probably way longer than I needed to. But here is one of their, systematic diagrams for how they approach searching different databases. So it really seems that Embase and Medline were some of their key databases that they like to search. Cochrane, the library, Google Scholar, and Web of Science. So they did nail all of these boxes that are in a solid black outline. They did search in all of those. However, we're thinking about an intervention that would be deployed in the ICU. And when we think about what or who really deploys these interventions in the ICU, it's typically nurses at the bedside. And that's why CINAHL would have been a great database for them to search. And as well as PsycInfo. They were looking at some outcomes that are related to mental health and that are related to psychology. So while they followed this diagram to a T, it's really important to consider, who are you actually, what is the population they're actually trying to study, and what are the outcomes that you think you might get in those included studies. So I think they might have missed some key groupings here to identify some studies for inclusion in their meta-analysis. So here is that Prisma flow diagram that I mentioned a few slides back. So their selection of studies identified in the database search for inclusion in their systematic review is shown by this diagram. Their methods for finding those studies included screening of title and abstracts, and 2 reviewers independently screen them to confirm adherence to their a priori eligibility criteria. And then from those 1% of studies that were included for full text review, they discussed for admissibility, and all disagreements between reviewers were resolved by discussion. And these numbers are actually quite interesting to me, because typically we see the reverse. We typically see being more inclusive with your title and abstract screening, because you're just screening on the title and abstract, and a bit more restrictive when you're looking at the full text articles, because you have the full paper there and you're able to make more decisive decisions and comments on the eligibility criteria. So that being said, I've raised a couple of comments and things of potential concern. Does anyone have any comments on what we've looked at thus far? If you were reading this paper and you saw those concerns, would you invalidate the study and keep reading, or do you think the perfect study does not exist and we must go on? Does anyone have any comments to share?
For those of you who are who want to engage, just feel free to unmute. If you want to, you can also do a reaction and just raise up your hand. I personally have a question. It seems that and I don't know if this just might be in the nuance, but to go from 1,000 papers, which is a kind of a search engine frozen in time, point in time snapshot, to now go to 10, I think was in that flow chart you had. How does one go and validate what they generate at that point of time was actually reflective in the composition of all the databases that they quote unquote studied?
Yeah, exactly. So this is actually a point where it's really, really crucial to include a medical librarian. I think I saw Dr. Lorenzetti join the call earlier. I don't know if she's still on. So if she is, please feel free to unmute yourself, because she's been the one who has, for me, trained me over the past 5 years at U of C, including a health sciences or medical librarian, helps you to develop that search strategy that is both feasible and practical. You can't screen 100,000 studies, even though you might want to be as inclusive as you want, and also meet your eligibility criteria or your PICO statement. It is good practice to include all of those PICO search terms as I commented on before, to know that you are pulling everything that you would want to, that may reach any one of those search terms that you included in your strategy. And another step of really good practice is to do a few pilot searches and to make sure that any articles that you've identified as you would include, because arguably you're doing something on a literature base that you know quite well, they get pulled from your search strategy that you have pilot run. So it's a really great question, and you know, the perfect search really does not exist, because we're not robots, and that's actually why we have seen a rise in manual or algorithms that help to screen title and abstracts after some humans have actually test run a few hundred or a few thousand.
So I have a question, Stephana. Yeah, I'm Pablo. Thank you. So this question is because you couldn't meet a so was there a target number of studies that you wanted to come up with using the search criteria? Is it?
Yeah, so there actually is never any sort of target number that you want to reach. In most cases, it's actually that you want to bring it down. Because I've done searches before that have pulled over 100,000 articles, and you really have to decide which terms you want to include in your strategy that will pull a feasible amount of studies that should capture the ones that you inevitably want to include. So there's never any sort of predefined number, but you do want to be as inclusive as humanly possible.
Or you can't humanly process thousands, right? Because time limitations. And so what's a practical number of studies to include?
Yeah, well, again, really good question. And it really ties down to what are you studying? So if you're studying a very extensive literature base and you're studying a question that has a lot of very broad search terms, you can get up to, I've done reviews that have had, I think it was 26,000 titles and abstracts to screen. And then I've also done a systematic review, for example, on bereavement interventions in the ICU. And this is a field or a body of research that is so underdeveloped that we had just over 1,000 title and abstracts to screen. So it varies very widely, and it depends on the terms that you're using and what you want to look at in your research.
Hi, I've got a question. My name is Cliff. With your assessment of 1% being and 50% of those being looked at, you said they're usually reversed. So you'd be going through 500 articles and then trying to narrow down that to 1%. So why is that necessarily a bad thing? I guess I'm trying to understand why the reverse would necessarily not be good,
worse.
right?
Totally. And it is worse. Trust me, mentally, it's a lot worse. And I get what you're saying. And the best way that I can explain it is actually like a Swiss cheese model, is because you don't want to exclude anything that you don't want to exclude anything that you haven't reviewed the full text on. So you want to be as inclusive as possible from the title and abstract screening. So think of it as like one slice of Swiss cheese. So it's like one level of screening. And when you go to the next level of screening, another slice of Swiss cheese, and you're doing the full text review. So this way you can be a bit more restrictive and you're very certain that it does not meet your eligibility criteria. So in title and abstract screening, really, you are looking to include anything that may meet your eligibility criteria, because you can't exclude it with certainty. You don't have the full text in front of you. But when you're looking at the full text review, that's when you want to exclude with certainty anything that does not meet your inclusion or exclusion criteria. Does that make a bit of sense?
Right. It does, but I guess I am concerned the fact that if I didn't have the correct terms in my abstract, then it probably wasn't a core aspect, and any understandings that you might pull out of that may not be aligned with what your expectations of the outcomes might be.
Exactly.
So I'm just trying to understand that logic.
Yeah, so it really ties all the way back to the correct search strategy, because if your search one of the terms that I was taught in my training was garbage in, garbage out. So if your search strategy pulls a bunch of garbage that isn't relevant, you're not going to be finding a heck of a lot of studies that are relevant to your outcomes.
Of course, and are they using NoSQL more? Like that looked like pretty much SQL. There was no nearness of terms in between or fuzzy search access to those in that search recommendation.
Yeah, that raised some red flags to me as well. Mm-hmm.
There's a question from Begnas Jafari.
Yes, hi. I have a question about searching, not just database engine, other resources that are, I think they're called gray studies, something like that. I wasn't at the beginning of your talk, sorry. So when we need, I mean, in what situation we should decide that, okay, we need to consider gray studies and to add to our search, and how much we should go deep inside that?
Yeah, fantastic question. And it's really the golden question, because as much as I'd like to say that every systematic review should search the gray literature, it's not feasible to do that. So I've been on both sides of it. So when you're looking for RCTs, typically they're going to be published, especially if you're looking for peer review published articles. You're probably not going to find that many in a gray literature search. If you are looking for any sort of study designs, or you're including conference abstracts on non-peer reviewed literature, then you would possibly want to do a database or a gray literature search. Another example would be, as we've seen through the past years, that preprint servers there's just thousands of articles that are going through these preprint servers now. So if you decide to include non-peer review preprint articles, then technically you would have to do another gray literature search. Systematic review and meta-analyses, gray literature searches are becoming less frequent, I would like to say. I'm seeing them less and less in published meta-analyses. A different type of literature review known as a scoping review, that's when that gray literature really comes into play, because you're really focused on the comprehensive view of a question, whereas with a systematic review and a meta-analysis, you're generally focused on the quality of the included studies in your review.
And thank you. And may I ask another question about the Google Scholar? When we search the main data sets, like the one that you mentioned, PsycInfo and other data databases. So do you think that it's still worth that we look at the Google Scholar? I mean, because it's a time, you don't want to.
I know it is, and to some, I've actually seen some papers saying that Google Scholar is considered a gray literature search. I personally do not do a Google Scholar search with every review. Sometimes I do with scoping reviews, but with systematic reviews and meta-analyses, if I get a very, very large number of papers pulled from the bibliographic databases, then I do not do a search in Google Scholar, because it's really a manpower thing. And personally, I've seen that there's a pretty broad overlap on the studies that you pull. But again, that's not an overarching like umbrella, do not use Google Scholar. I think it really needs to be approached on your review and the question that you're asking.
Thank you.
Okay, awesome. Well, thanks for being so engaging. This is fantastic. It's so rare that this happens, especially at 6 o'clock at night. So I think that we'll move on to our second sort of group that I want to talk about that will typically critically appraise in a systematic review and meta-analysis. And this is regard to publication bias and small study effect. And I want to take a second to step back and actually give some definitions for these two terms, because unfortunately we see them mixed up quite a bit. So publication bias is when statistically significant results compared to non-significant results have a better chance of being published and are published earlier. The small study effect is when small studies have systematically different effects compared to large studies. And the small study effect can result from publication bias. And this is because it's been suggested that small trials tend to report larger treatment benefits than larger trials. And this is just due to the sample size of those small trials. And how we typically assess or investigate small study effects is through a graphical tool called a funnel plot. And I've showed this on the right here. A funnel plot is when the effect, so here we've got the log odds ratio on the x-axis, and on the y-axis we've got standard error or precision, which is related to study size. And something to note here before I walk you through the funnel plot is that small study effect is not equated to publication bias. And this is because there are many sources of heterogeneity and funnel plot asymmetry. So to those who haven't seen the funnel plot, I'll just take a quick second to orient you to this tool before we look at the one that was published in the study that we are appraising. So right here down the middle, this is our overall effect line, and we've got our dashed lines on the side that represent our 95% confidence intervals. Up here with this pink box, these would be our large studies that have more precision, and thus they are more powerful studies. On the bottom, we've got a grouping of less powerful studies with a lower precision and thus a smaller sample size. So that's typically what a funnel plot looks like. If we're looking at the funnel plot that was published in the review that we're critically appraising, this is the one that I took right from the paper itself. And the author stated that scattering in the funnel plot is symmetrical, therefore the risk for publication bias is considered low. But they didn't consider, and I've addressed some exclamation marks up here, is that all of their studies tend to be of the smaller size. There really isn't many studies that are quite a bit larger, and they have a larger patient population included in them. So while the authors are correct in saying that, yeah, it's symmetrical, they kind of missed a whole area to talk about differences in sample size in their included studies. So just a quick pause. I know we had a really great discussion a few minutes ago, but taking one step forward, would you invalidate this review based on publication bias and small study effect? Feel free to just do an response or an emoji or whatever it is if you don't have any questions at this point. And as I see you raised your hand.
Sorry.
Were you agreeing?
No, I wanted to bring it loud, but
oh, okay, that works too.
I have a question about like the validating the sample size.
Sure.
So like if you're working with something like rare diseases, do you take kind of what the literature is saying is a large sample size or a small sample size, or do you take a median value or a mean value of the meta-analysis that you do? Kind of like what are how do you justify what is considered small or large?
Yeah, interesting question. And I was actually hoping someone would bring this up because if we think to the population that we are considering in this review, we're studying ICU patients. So those people in and of themselves, well, ICU and surgical patients, if they met the eligibility criteria and they agreed to consent to the RCTs, they wouldn't be large trials in and of itself. So to my opinion, no, I wouldn't invalidate the study because the authors are dealing what they have to deal with. So for your example, Kelly, if it was a actually, I forget what your example was, a rare disease in general, you're not going to find large RCTs, especially. You might find larger studies in a cohort study or like a prospective or retrospective cohort study, but I wouldn't have invalidated this one. I think it's fine that they had, relatively smaller sample sizes, but just to be transparent, I think that should have been mentioned in their review somewhere.
Thanks.
Okay, I think we'll get going to the next one. This is the fun one. This is where things start to get a bit messy. And we look at the quality of the included studies. And so why we do this third step is regarding internal validity. And that's because it may be affected by errors and incorrect evaluations during all phases of a clinical trial. For example, selection, performance, attrition, and detection bias. So the assessment of the risk of included study bias is a really central step when one carries out a meta-analysis. And I used a term earlier, I think with Pablo, one of my responses, garbage in, garbage out. So here's our chance to really see how much garbage did we actually bring into this review. And how quality assessments are typically done, which are key to determine the strength of inferences. And we'll see in a second, it's important to assign grades of recommendations. They're typically done with the Cochrane risk of bias tool. And the authors used exactly that. We can see the green bars are regarding low risk of bias, and it's proportional to the number of studies that were included in the meta-analysis. Unclear risk of bias in yellow, and then high risk of bias in red. So nothing to really flag here other than that the authors correctly noted that risk of bias was moderate to high for sleep quality, which was one of the outcomes that they really wanted to look at. So just something to keep in mind, if they found high risk of bias in their included studies for one of their key outcomes, it impacts our interpretation of their meta-analysis. So as I mentioned, those quality assessments are key. So risk of bias assessments are key to assigning grade recommendations from these studies that they included in their review. So a strong recommendation suggests that all or almost all persons would choose the intervention under study. So in this case, all or almost all critically ill patients would want music therapy in the ICU or the surgery wards. And weak recommendations imply that there's likely to be a variation in decision-making that informed persons are likely to make. So what's typically done to make these recommendations is the grade criteria. And they use just that, is the grading of recommendations, assessment, development, and evaluations criteria. The grade criteria ranges from very low certainty to high certainty. So a very low certainty, for example, would be that the true effect is probably markedly different from the estimated effect. And then a very high certainty is when the authors have a ton of confidence that the true effect is similar to the estimated effect. Certainty can be downgraded for risk of bias, imprecision, inconsistency, and certainty can be rated up for example, large magnitude of effect and any dose response gradient. And this one too is worth considering, is that all residual confounding would decrease magnitude of effect in situations when a significant effect is actually seen. So, and now here's where things get interesting. With this study in particular, the authors chose to not follow the typical process for grade ratings. And the typical process is when the grade quality of evidence ratings are applied to each outcome that the authors wanted to study or chose to study, included in the studies in their systematic review. So here's an example. It's not from this systematic review of the grade ratings that are applied to each of the outcomes. And as well, in addition to all of those outcomes, an overall grade quality rating can be applied to a body of evidence across outcomes. So this is what one would do. this is what the authors did do. They chose to choose imprecision, inconsistency, and heterogeneity. So they chose three factors or variables that would typically be used to downgrade your certainty of evidence. And then within those three, they gave their own sort of ratings for those three factors or variables at play. So they chose imprecision. They gave imprecision a medium quality, which I don't know what that means really. And then they also looked at consistency. I don't know if they meant inconsistency or not. And they chose to rate that as moderate to high. They looked at heterogeneity, which was rated at moderate to high. And then they gave an overall rating of moderate. So this is one of the, I'm actually quite surprised that this actually made it all the way through peer review, stating that they used the grade process and the grade tool, and they cited that process in their paper, yet it was very much not what is typically seen when grade is used to rate or to give some recommendations. So just something to flag here in terms of their actual quality rating and recommendations for their systematic review. Does anyone have any questions on that process or some red flags seen for others before we move on to the next section?
I do have a question, Stephana. Thank you. So how do you, this is going to sound a little funny, but how do you check for biases on the bias checker, let's say, on that process of checking? How do you check on that, and who determines what is biased and what's not? How is that incorporated in the study?
It's a great question, actually. I haven't had that one asked before, but a good question, because there's lots of different tools to look at different biases, and the tools are typically or they are developed and made and validated for different types of study designs based on common epidemiological biases that we typically see in that study. So for RCTs, the biases that it would really look at would be detection bias, so unblinding of participants, or attrition bias, where participants would be lost to follow-up. In prospective and retrospective studies, we would be very concerned with more measurement bias, if there was self-reported bias or recall bias, social desirability bias. So really the tools that we use to look at the study designs are developed for those particular study designs. And that's a fantastic question, is, as we learn a bit more and as our knowledge base grows, there might be more biases to add to those tools. So having a good understanding of the tool that you're using, and then also any additional biases that you might want to look for, is a great standard of practice. I have seen some systematic reviews that have used one particular tool, and then they've added on additional columns of bias that they think would be really important, just given their patient population or the questions that they're answering. So there's no like hard and fast way. I apologize.
No worries. Thank you.
Okay, we'll move into the final section, which is data analysis, which I'm sure you guys are all very excited about. The point of taking this long to get to this fourth section is to show how important each of those earlier steps are before you get to actually play with the data, which I know is what we all love to do. Getting a new data set is just Christmas for all of us, but making decisions on data analysis really need to be informed by all of the steps that come before it. So in speaking about that, and you might be wondering why I had a floaty on the previous page, it's definitely not summer here anymore. One of the key questions that we want to ask when we are conducting systematic reviews and we want to conduct a meta-analysis is to pool or not to pool that data. So considerations with regard to pooling the data should be made focusing on sensitivity and risk of bias, rather than statistical measures of heterogeneity. And I am taking a bit of a controversial stance on this, and I'll have two arguments down here just to back up that statement. First is, in the absence of heterogeneity, even though you might not have heterogeneity, you might have statistically insignificant or non-statistically significant heterogeneity, combining results from biased studies will produce equally biased combined estimates with really narrow confidence intervals that could then be interpreted wrongly as definitive evidence. Conversely, conducting a meta-analysis in the presence of heterogeneity might actually be quite appropriate when studies are at low risk of bias and our results are qualitatively consistent, which might indicate some degree of benefit or, in contrast, risk. So if we were to do if we were not to do a meta-analysis, so no meta-analysis, it's still fine. A systematic review that documents heterogeneity and risk of bias will still provide a very valuable contribution to the literature, even without a formal meta-analysis. I think it's more important to not have a meta-analysis from very biased studies than to have a meta-analysis, an extra figure in your paper, and something that could be interpreted quite wrongly. If we were to do a meta-analysis with a group of studies that is low risk of bias, but has high, relatively speaking, heterogeneity, quantitatively detecting subgroup effects, so really exploring those heterogeneous populations and just demonstrating external validity, is also a very valuable contribution to the literature. So even though when you pool everything in a meta-analysis that has high heterogeneity, you might not have a very clinically impactful result, it might not dictate clinical practice, but it's a really strong form of a literature review for future research and areas of inquiry moving forward. So the authors here decided to do a meta-analysis, shockingly. And they stated that since the eligible studies included hospital patients who have a compromised physiology, which has impact on the patient's comfort and thus sleep, the data were suitable to be pooled. I personally have a very hard time interpreting the statement or their justification for pooling the data. Basically, they're saying is because they were really heterogeneous, the data were suitable to be pooled. Perhaps my thought was like, okay, perhaps they want to go forward and look at subgroup effects, some sort of meta regression, for example. They actually didn't go forward and do that. They didn't look at different subgroup effects at all. So their justification was a little off to me. They were pooling very, very different patients without having any sort of justified reason to do so. And one more note on that is typically you'd need a relatively large number of studies to do any sort of subgrouping that would be that would result in an adequate number of studies to do the subgrouping analyses. So for example, I recently did a systematic review where we included 102 studies in the meta-analysis. And with that one, we were able to do 6 different subgroups. And I actually have a figure on that at the end of this presentation. So 3 really quick points here. I know that we're trending toward the end of our session, but I'll go through this in as much detail as I think is necessary. 3 points on data analysis. And I have seen these confused in the literature all of the time. And what I mean by confusing is equating one of these statistical tests to between study heterogeneity. So I'll give it away. This bottom one is the actual measure of between study heterogeneity. What we often see in the literature as an interpretation of between study heterogeneity is the Q-test and the I-squared test. So the Q-test assesses whether the variation between estimates is likely due to chance alone. So as I mentioned, it's not a measure of between study heterogeneity. It's a p-value, so it assesses a statistical test. The I-squared quantifies the proportion of observed variance that reflects real differences in effect size and cannot be attributed to chance. And again, this is not a measure of between study variation. What is a measure of between study variation is the tau squared, and this is a point estimate measure of the variance of the true effect. So here is the first of two meta-analyses that the authors included in their review. We can see that the Q-test, the p-value that was demonstrated, is below 0.05, so it's significant. The I-squared results in a value that is 85%, and the tau squared resulted in a value that is 0.55. So it doesn't look like there is too much between study variation here. It doesn't look like it's a very heterogeneous population that the investigators are studying for their systematic review. They're all on the one side of the standardized mean difference null value line, and the 95% confidence intervals, save for this Zimmerman study on the bottom here, do not cross 0. They also did another meta-analysis where they removed, what study was it? Yeah, Chiragi and colleagues. And the study, if I recall correctly, had a bit of a wonky methodology in how they assessed sleep quality. They pooled all of the data except for that one study that they excluded. And the authors stated that the pooled data excluding that study continued to show that significant effect. And this was a study that they rated at high risk of bias. So we can see that the Q-test, the p-value here is 0.14. The I-squared is 45%, and the tau squared is 0.08. So if we're comparing this one to this one, even though they look, relatively similar from first glance, excluding that study, the Chiragi study that's way off in one direction, resulted in a much more homogeneous group of studies that they included in their meta-analysis. I had a lot of trouble interpreting these two paragraphs in their paper. And I copied it directly from their paper. So these spelling mistakes are not my own. And you guys can all, I included this for a bit of a giggle, because if anyone knows proper data analyses and methodology, it's the group I'm speaking to right now. So what the author said is, since our meta-analysis eventually only included subjectively measures sleep assessment tools, the back transformation was based on a recent Dutch study that assessed sleep in 194 patients using the RQSQ, which is a validated and reliable sleep quality assessment tool in the critically ill. And from that justification, they made the approximation of 27.1% increase in sleep quality if a music intervention is applied based on our pooled data. And they also said that several studies comparing benzos to a placebo showed lower efficacy, ranging from about 13 to 21% improvement. So their 27% with the music intervention seemed like a much better intervention than any sort of pharmacological interventions. The problem here is that they're making approximations based on aggregate data. There have been systematic reviews that have gone ahead and collected individual data from all of the included studies, so individual patient data, so they can actually create that amalgamated data set to make some sort of approximations. We see this quite commonly in individual patient data meta-analyses that have looked at correlation. So maybe R-squared values, they can look at differences in standardized differences, increases or decreases based on the other variable that they're studying. It's less common that we see this for RCTs, especially RCTs that haven't looked at individual patient data. So this is really just something to flag, in that not only did their methods really not make a lot of sense, but it's uncommon to see any sort of broad comparison, broad approximations without really rigorous individual level patient data. So I'm going to skip through this slide and I'll show you the next two slides before I save room for questions at the end. But the next question would be, would you invalidate this review based on their data analysis, keeping in mind all of those earlier flags that we raised prior to talking about those forest plots that I showed on my previous slides? The next two slides that I actually wanted to touch on really quickly, I know we're trending toward the end of our time, is talking about recommendations from the systematic review and then actually comparing STATA and R and those forest plots that are routinely generated. So at the end of a systematic review and meta-analysis, just to round us off, more research is needed. It's really not a great way to end off months of screening and reviewing papers and statistical analyses. You are in a much better place to make really detailed recommendations for and on specific studies that you included. And for the critically appraised study that we talked about tonight, they said that large RCTs should be needed. So here's where they brought in the large RCTs part, is that they recommended future studies should focus on larger sample sizes with high methodological quality in order to avoid a substantial risk of bias. They also called for studies with music interventions with objective assessments, such as the type of music, timing, duration, frequency of intervention as sleep assessment, using tools that are validated and reproducible. And they also called for clinically relevant doses. And again, they made a suggestion of a minimum number or minimum amount of minutes per day where an ICU or surgical patient could listen to music and be much better off. So better sleep quality and sleep quantity. Not sure I agree with 30 minutes. There's many days that I listen to 30 minutes of music and I just sleep horribly. But then again, I'm not an ICU patient or in the surgical ward. So just some considerations for what are they recommending, and if they are recommending it, it's likely because they did not see that in their systematic review. So I always like to take a step back as soon as I read their limitations paragraph and their recommendations paragraph, and then go back to the meta-analysis and think, okay, if that's what they're recommending, then are the results really interpretable from the meta-analysis that they are presenting? And just to close this off, two more quick slides here. Chell was really, really generous in that he helped translate my meta-analyses from a review that I previously published. Again, surprise, in critically ill patients. Actually, they're informal caregivers of the ICU patients. And I did mine in STATA, and Chell very kindly translated my code to R. And I just wanted to show maybe a bit of a different meta-analysis than we typically see. So in the ones that I published, and I mentioned this a bit earlier, is we actually saw very high heterogeneity. So for example, here, you can really see, zoom in, the I-squared value, excuse me, is 97%. For this one group up here, and then 90% for the group down here. And this is a bit different than the one that we critically appraised, in that we had a very, very large number of studies where we could actually do subgroup by the type of psychological outcome that we wanted to look at. So for here, we're looking at anxiety, and as well by the time point of follow-up from the patients that were included in the studies, or the family caregivers that were included in the study. So we were able to, despite a very heterogeneous population, we were able to publish a fairly good manuscript looking at potential differences or gaps or holes in the extant literature that might need to be filled. So this is a forest plot of ratio of means that that we produced in STATA. And here is what it looks like in R. It looks a bit different. Again, we see things that are relatively similar. We get the ratio of means. I think what Jill's produced here is the log ratio of means. We have the standardized error. And then we have the 95% confidence interval, as well as the weight that is included in the systematic review or in the meta-analysis. So just to close us off, I have a lot of time to stay for any talks or any questions or comments that you guys would like to talk about this evening. But I'd like to close this off by saying I spent an hour talking to you about meta-analyses. All of the knowledge that I've talked about tonight has been imparted on me by wonderful, wonderful colleagues at the University of Calgary, my supervisors, and a lot of the teachers that teach, a lot of the instructors that teach the systematic reviews course. So there's many courses that you can attend, lots of info sessions if you'd like to learn more. This was just a very, very quick overview of some of the things that we typically look for when appraising a systematic review and a meta-analysis. So thanks very much.
Thank you.
Wow. Yeah, no, thank you, Dr. Moss. That was really good. You know, before we wrap up the formal part of this presentation, I loved the presentation. It was really good. Coming from a different background that's not clinical, I found that the approaches that you highlighted to detecting bias, or even just qualitative analysis, to be very refreshing and interesting. It's something that I'm definitely going to take back to my work. So no, it was a wonderful presentation. Thank you very much for sharing your knowledge with all of us today.